want to start today by talking about substance use disorders and kind of what our vision is moving forward in terms of with the behavioral medicine team. What I want to do is give you an overview of substance use disorders, how to screen for substance use disorders, and how to diagnose them. I want to talk about the treatment around substance disorders, specifically MAT, medication-assisted treatment. Mainly in the setting of opioid use disorder and alcohol use disorder, and talk about our vision for a collaborative care model here at Norton, and then how you refer and work with us in behavioral health to help co-manage these patients. So I want to start with a case because we in the medical field really like cases. We like to kind of work with what we know and how we learn in a case model. So Mr. Smith is a 54-year-old male with a history of alcoholism, heroin use, methamphetamine use, bipolar disorder, hypertension, hepatitis C, and COPD. He's in detox 4 times over the past 8 years. He has no consistent medical care prior to 1 year ago when he became incarcerated. He's released from jail a month ago. He smokes a pack of cigarettes per day over the last 40 years. He also has a history of 4 overdoses between alcohol and opioids and 2 suicide attempts. He reports significant trauma as a child, teen, and as an adult. He has limited support, no income, and he does have his GED, and he comes to us saying he is motivated to turn his life around after getting out of jail. So I just want you to keep that case in mind because we're going to visit that at the very end of the presentation. But I want to show you that Mr. Smith here falls in the middle of this Venn diagram, where we have in the United States an epidemic of co-occurring disorders. And when we say co-occurring disorders, we're talking about substance use and mental health. And interestingly, and this is in 2017, and the numbers have only gone up since then, we have about 20 million people with adults with substance use disorder, and we have about 43.6 million adults with mental illness. This makes up about 6% of our population. The mental health aspects makes up about 13% of our population in the United States. So I also want to say that there's another bubble here that's exactly this big, and it's about 13% of people that don't have a diagnosed substance use disorder yet, but they actually have harmful use. And this is an area of opportunity to prevent people from going from harmful use to an actual substance use disorder. And again, that is about 13% of the population. And in primary care offices, that amounts to about 20% of the primary care population. So looking at the numbers, these are overdose deaths in the United States. And I will say every single metric on here has gone up since 2016, and now in 2018 was the latest data that we have. All of these are going up. And benzos are also in here, and they have gone up too. They are now starting to plateau. So as you can tell, this is a significant issue in terms of overdose, people using substances, overdosing, and dying. I want to impress upon you the importance of thinking as addiction and substance use disorder as a chronic disease. And this is ASAN, the American Society of Addiction Medicine, and it defines addiction or substance use as a primary chronic disease of the brain, its reward system, motivation, memory, and related circuitry. And it involves cycles of relapse and remission, which is very similar to what we see with other chronic diseases. This concept of substance use disorder and addiction as a chronic disease is supported by many, many professional organizations. This happens to be the ACP, again, chronic treatable medical condition. And I want to talk about adherence as it relates to other medical conditions. And what we see is that, yes, in fact, when we look at the adherence to treatments, over time, we see substance use disorders on par with our many other chronic diseases. So I want to just introduce what is medication-assisted treatment or medication for opioid use disorder. And I'm going to use this in the context of opioid treatment and alcohol treatment, but more specifically opioids. So buprenorphine or Suboxone, which is the combination product that has naltrexone in it, is a partial opioid agonist, which I'll talk briefly about. It comes in two forms. It comes in the mono product, which is called Subutex, but it's the combination product with naltrexone also has the opioid blocker in it, which is naltrexone, which is a opioid antagonist. And the reason for that is to minimize the abuse potential. So if a patient takes Suboxone or Subutex or buprenorphine, well, actually, if they take Suboxone appropriately sublingually, like under their tongue, then they will get very little of the naltrexone in their system. So you're giving them a partial opioid agonist, and then there's a blocker in it. And really, the only way the blocker comes into play is if they use that through intravenous methods. So that's the whole point of the naltrexone in that combination product. It's important to prescribe the combination product instead of the mono product. The mono product clearly has much more abuse potential and has a higher street value. So naltrexone, like I said, is an opioid antagonist. That comes in two forms. It's the oral form and the injectable form. And we have much more data on outcomes and effectiveness of the injectable form, which is called Vivitrol. And that is used, again, for opioid use disorder, as well as for alcohol use disorder. And it's now starting to be used for methamphetamine use disorder with some promise. So the trick with naltrexone is that you have to be off of opioids for at least 7 to 10 days before you put an opioid antagonist in their system. And then methadone is another option in this repertoire. It's a full opioid agonist, and there are specific facilities that treat with methadone. And so I want to talk about just MAT and the use of those medications and the effectiveness briefly. So what we see, and this is an old study in 1971, and who just followed people over time with basic interventions back in the day in terms of abstinence-based treatment, and they just followed people over time and found that many people dropped out and were unable to remain abstinent or free of substances in those first 3 months. So you get a very steep drop-off with all of these substances in the first 3 months. But what they found is that you continue to see drop-offs through 12 months, where those who are able to remain abstinent in a year is anywhere from 25 to 35%, which is pretty low. So we have a lot of data on the effectiveness of Suboxone, buprenorphine, and what we see is that as patients are engaged with MAT or medication treatment-based treatments, we're able to keep them into care. The longer we can keep them into care, the better they do. And so this is maintenance and treatment. So looking at people over a 12-month period, we're able to, with MAT, we're able to keep them in, and this is actually done in a primary care setting. So in primary care, they were able to keep these patients in care and engaged at least at 12 months at least a 60% level. And then what we find is the longer they're in treatment, the less opioid use that they have over time. And this signifies opioid-free time. And then in terms of mortality benefits, without treatment, patients have a six times the likelihood of death without treatment for opioids. With MAT, with medication-assisted treatment, that drops down below 2, not quite to the general population, but we're close. So I want to switch gears briefly and talk about screening, because for those of you who are in primary care, this is really important. because even if you're not treating substance use disorder, it's important to address the 13% of people or the 20% of people that might be in your practice that clearly have harmful use with substances, and we want to prevent them from getting an active use disorder. So this is for alcohol. This is the recommendations by the USPSTF, and this has not changed. This is a B recommendation in terms of screening. So adults 18 and older should be screened for alcohol use. And again, a B recommendation means that there's at least moderate evidence to support a clear benefit in screening. There are different tools to screen your patients, which I'll list in another slide. But there's many screening tools out there, and it usually doesn't take a lot of time. If there's a positive screen, then there's some brief interventions that need to occur when that happens. So this just came out, and we kind of knew this was coming out for the last year, but it's officially out. This is the new USPSTF guidelines for substance use and screening for drug use. So this has now gotten their B recommendation. So again, like alcohol, screening for drug use is critical in the primary care setting. There are various tools to do that, which I will go into as well. But again, this is new, and I want everybody to know that if we're going to be able to tackle the opioid and the drug epidemic, as well as the co-occurring epidemics that are going on, then we're going to have to not just treat them when they have a clear substance use disorder, but think about the entire continuum of care and how we screen and then and intervene and treat along that continuum. So here are some screening metrics and screening questionnaires to do. This one is very simple. It's the single question screen, and this is for drug use. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? SBIRT, I'm sure you're all familiar with, is another tool. The DAS-10 is a little bit longer. Alcohol, CAGE, audit, and SBIRT are all options for screening in for substance use disorder or harmful use in the primary care setting. So I want to go briefly into diagnosing substance use disorder, because I think it's important for people to understand not just the screening parts of things, but how do you actually diagnose something? How do you actually diagnose substance use disorder? And this has changed recently. So we used to go by the DSM-IV criteria for substance use disorder diagnoses, but now that has changed in 2013 to the DSM-V. And previously, it focused on dependence and abuse. And that is not in the DSM-V criteria. Instead, what they did was they put all of these together in one scale to come up with a mild, moderate, or severe diagnosis. So we have a scale now of addressing mild, moderate, or severe disease. And so what addiction or substance use disorder is it's defined by a loss of control and negative consequences to use. Now, previously, dependence had to do with loss of control and physiology. And then abuse had to do with the negative consequences of use. So what I would like you to understand in terms of the transition from this is that from the DSM-IV to 5, from dependence and abuse to mild, moderate, and severe, is that tolerance and withdrawal alone don't necessarily imply a substance use disorder. And this is important because, again, so you have to have 2 or more of any of these in the past year resulting in distress or impairment in order to satisfy the diagnostic criteria for substance use disorder. And tolerance and withdrawal by themselves do not necessitate a disorder. Why? Because if there's no distress or impairment associated with that, it's not technically addiction or disorder, use disorder. And the reason why that's important is because we have lots of patients who are on long-term opioids who are clearly tolerant, and they clearly have withdrawal if you take them off. But they don't have any loss of control associated with their use, nor do they have any negative consequences associated with their use. And that's a really important distinction. So as prescribers and providers and diagnosticians moving forward, I strongly encourage you to use this criteria moving forward in terms of diagnosing a use disorder. There's an opportunity to do just tolerance or withdrawal in and of itself, but a substance use disorder by itself, which will necessitate significant more amount of care, should be diagnosed under this. And this is the specific criteria and the questionnaire which each patient should be asked to appropriately diagnose their substance use disorder if they have a substance use disorder. And again, they have to meet at least two of these 11 criteria to satisfy at least a mild use disorder. And here are some DSM-5 and ICD-10 codes. And what I want to show you about this is not the codes itself, but specifically that the substance use disorder coding and diagnosing is simply based on the substance of use. So alcohol use disorder, opioid use disorder, cannabis use disorder, sedative use disorder, cocaine use disorder, it's all the same. And it's all these questions. It's the exact same questions. It just changes based on the substance. So with that, you are able to identify it's a mild cocaine use disorder because they've met 2 out of the 11 criteria. It's a severe opioid use disorder because they've met more than six or more, et cetera. So this helps us get very specific in terms of the severity of their use disorder and the specifics of that. And there's just some modifiers that I just want to touch on because this confuses lots of people. One is the remission, and how do you assess if somebody's in remission or not? Well, here's how you assess: is they've previously met the criteria for substance use disorder. Again, at least 2 of the DSM-5 criteria, and then they have not met them for the last 3 to 12 months. So that means they're in remission. The exception to that is craving, because everybody has craving to some degree or another in some format with substances, even months and years after they stop that substance use. So the only thing that does not count in that criteria for remission is craving. The same thing with the sustained remission. The only difference is this is greater than or equal to 12 months. And then another caveat is, are they on maintenance therapy? And that is specifically for opioid use disorder, if they're on methadone, buprenorphine, or naltrexone treatments. And then, are they in a controlled environment? So if the patient is in a controlled environment, this is where access to any substances is highly restricted. For instance, jail, prison, a halfway house, recovery center, those kind of places. I briefly want to touch on the neurobiology of addiction and the motivation rewards pathway around this. And most of you I'm sure are familiar with this already. But I just want to say that the brain is very complicated. It's very tricky, and yes, part of it is chemistry. And that's from a medication standpoint. That's what we try to target and try to intervene with outcomes. And I think we're very successful with that with MAT. But it's a lot more complicated than that. But just to be very brief about this, the addiction process basically hijacks the brain in the reward pathways, and this is the positive reinforcement pathway, where the brain gets exposed to a substance and it likes it a lot, it wants it, and it keeps cycling through that. So it seeks it out and it wants more of it. And so you get this cycling going on where, the substances, and the stronger the substance, the more it just hijacks that brain. It hijacks that pathway. And what it does in one of the major consequences of that is that it causes a dissociation between the prefrontal cortex, which, again, the prefrontal cortex is about attention, thinking, and judgment. So this is the much more mature part of the brain that helps people, keeps them from not from doing things that may harm them. It's about control. It's about negative consequences. It's all of those things. And so in order for us to, there's a constant balance between positive reinforcement and negative reinforcement. I think there's some feedback. If everybody can mute their... So there's this balance between positive reinforcement and negative reinforcement constantly going on in the brain. And this is the ultimate mediator is the prefrontal cortex. And when that becomes dissociated because these pathways get hijacked with these very controlling substances, people make very, very poor decisions. We've all seen that. And this is another reason why it's important to think of this as a chronic disease. I want to touch upon the opioid withdrawal symptoms because, before I went into addiction, I didn't quite grasp the significance of this until I saw people in health. And I will tell, people will do almost anything from going into withdrawal. And they liken it to, they feel like they're going to die. So a lot of times they kind of get into this mode where all of a sudden they're trying to survive, and they will take whatever they need to take to just get out of withdrawal. And what people talk about Suboxone or buprenorphine being used in the street, and really it's something that will allow people to get out of withdrawal or not make their withdrawal so bad. And so I want to talk about a little bit more about precipitated withdrawal. And so everybody who's using an opioid has some level of, in their brain, they have some level of kind of opioid saturation related to their opioid receptors or their mu receptors. And so if people are on a full agonist, such as morphine or methadone or heroin, their brain is seeing a lot of opioids. And then if you drop them to a partial agonist like Suboxone or buprenorphine, they have this deficit. They have this opioid deficit. So they are going to experience withdrawal. No matter what you do, they will experience withdrawal. The same thing going to an antagonist such as naloxone or Narcan and naltrexone. The question is, how far do they drop? So if you see patients who present to the emergency room or through emergency services who just had an opioid overdose and they get Narcan, you're dropping them from here to here, and people instantaneously have a precipitated withdrawal and feel absolutely terrible. So this is naloxone, and this is the emergency reversal agent that has really been utilized quite a bit in the community now, and it's saved many, many lives. So I highly encourage providers to prescribe Narcan or naloxone to anybody. This is just my personal preference, to anybody that's getting naloxone. I've seen people who have had family members, even children, that have gotten into medicine cabinets and taken opioids by accident, and they don't have Narcan around. That's a problem. So it's not just an individual patient precaution, it's a community precaution. to get Narcan out there so that for anybody who needs it in an overdose situation. And then what we are trying to do here at Norton through behavioral health is to build a collaborative care model around substance use and co-occurring disorders, mental illness. And this starts with the patient, but it also involves lots of team players and lots of collaborators, such as community partners. And Scott Hesseltine will be talking later, and he will talk a bit more about that piece. But primary care is essential because primary care is a great avenue to establish long-term relationships with patients. And, you know, all of our patients, every single patient that I have in addiction always has a medical problem. This is not, there's always something that needs to be addressed in addition to the co-occurring substance use issues as well as the mental health piece. Specialists come into play, hospitalists, emergency providers, and many, many others. So building a therapeutic relationship with patients who are using substances is critical. And I find that some have challenging personalities, some have challenging circumstances, but they also have had very negative experiences in general with the healthcare system, and they're very fearful around that, and the stigma that they feel is high. And so I will say that, you know, as I've engaged with patients, they've surprised me in terms of how they've turned around, or, you know, and sometimes the initial, this is a chronic disease, so that initial interaction may simply just be an initial interaction, and how do we work with them to help them improve their health and minimize their use, and in the hopes to abstain and continue into recovery. And I think when we're able to do that, and when we're able to partner with them and kind of respect where they're at, but still hold boundaries and create shared goals, I find that outcomes improve. So substance use screening, we kind of already went through that, so I'm going to skip that slide, but I will encourage you, the first parts of this is to, in interfacing with a patient that may have a substance use disorder or harmful use, it's very important to first screen them. And then get the diagnosis right. Use the DSM-V criteria, get the diagnosis right. And then if they do have a substance use disorder, it's critical to ask them, are they interested in treatment? Are they interested in help? Because some people will say, no, I'm not interested in help. I don't have a problem. But it's important to kind of discussing this with the patient periodically, because at some point, they will get to the point where, yeah, I'm ready now. And they want to feel that they can come to you when they're ready. So this is a continuum of care, which Scott's going to get into much more deeply than I am. But I will say that people that have substance use disorder are treated not just in an outpatient setting. This is the early intervention, which is for harmful use, but not just in an outpatient setting, but there's other avenues, higher levels of care where you step up and step down their care based on their needs. So it is truly a continuum of care for these patients, not just you're on MAT or Suboxone for the next, 10 years or 3 years or 3 months. It's there are other aspects to how, if they relapse, kind of reassessing their treatment plan. These are the dimensions of care that we use to assess their best place of care. And then office-based care, which would be more in the primary care setting, and it's important to establish a diagnosis, understand the co-occurring disorders, especially the mental health pieces that occur with that, and then ensure that they can adhere to the appointments and drug testing recommendations. And the important thing about that is treatment agreements, where patients it's important to establish boundaries. This is a controlled substance. You want to establish appropriate boundaries for patients not diverting the medications, and then understanding that there are consequences if they do that. And so it is a collaborative effort with the patient, but we do have to put appropriate rules in place for that to happen. And lastly, I want to talk about the importance of treating the whole patient. And this is part of the collaborative care model that we're trying to establish, which is in MAT, me as an addiction physician can work on the physiological pieces of patients. And in fact, I think we do with MAT and Suboxone right now and naltrexone. We're able to do this very well in other adjunct medications, but we're able to really be extremely effective, and that's clear in the literature as well, in terms of the pharmacological and the biological pieces of addiction and withdrawal. But there's lots of behavioral pieces that we have to work on, and that is long-term management with a patient. It's long-term counseling and therapy, and appropriately diagnosing co-occurring mental health disorders, learning, managing their environment, which is, again, Scott's going to talk about that as well. But it's a complex issue, and we do have to focus on treating the whole patient. So this is who we are at Norton, the behavioral medicine team at Norton. We include psychiatry in terms of assessing and diagnosing a patient. We also do addiction assessment and treatment, and we also have the psychological components, including therapy and counseling. And we also work with partners in the community as well to step up or down the care appropriately for a patient as needed. And it's going to take a village to turn the opioid epidemic around, and substance use issues around, and the co-occurring disorders around. And this is a start. So I want to just briefly touch on the importance of cognitive behavioral therapy and how really getting patients to understand, and what I'm able to do usually in the first 3 months is to kind of stabilize the physiological pieces. And this is when the CBT comes in and becomes incredibly important for patients to now start to rewire their brain and understand that what their behaviors are doing, how are they harming themselves, et cetera, and then put tools in their toolbox and skills that will help them make different choices when they're triggered by something that pushes them or they feel like they're going to use in the future. So I'm going to go back to the case again. So Mr. Smith, this is his history. He was in detox. He was in jail. He's now released. He's got a significant history for co-occurring disorders, but he also now has medical problems as well that have come to light, and he is now very motivated. So he sees a provider for his medical care and primary care for his hypertension, his Hep C, and his COPD. But he's also seeing an addiction provider for his substance use disorders that are also associated with significant withdrawal issues and insomnia. And he now has an appropriate diagnosis for his bipolar disorder, and he's also diagnosed with PTSD. So a patient like this, he will fall through the cracks, and I've seen so many of them, if they're just in one silo. If they're in a silo of primary care and all this is not getting addressed, this patient will not improve probably in those areas. Maybe the Hep C, because there is a cure for that. But it's vitally important for us to all collaborate and help this patient. And the reason for that is it improves lots of things. It improves the care from the patient perspective. It improves their access to care. It improves the efficiency in which that care happens. It improves the knowledge sharing of the team. Everybody grows in knowledge. Everybody improves with communication, and it becomes more of a team-based care, despite not necessarily being co-located. And then the quality of care increases, and ultimately his outcomes increase. And I'll say that many people with use disorders, substance use disorders, also have chronic medical conditions as a result of the use disorders. So if we can catch them as early as possible to prevent that, that is ideal. So how do you partner with us? So in EPIC, we have an ambulatory referral for behavioral medicine. So that is what, that's how to refer. And then I also want to make a plug for our medication-assisted treatment training waiver that's coming up in September. So September 25th, 26th, December 11th. We would love to see you there. If you are interested just in learning more about MAT and substance use treatment and the disorders itself, then I would encourage you to come. And especially if you're interested in thinking about treating patients, I would encourage you to come. And that's my contact information if anybody would like to get in touch with me. So I appreciate your time. Thank you. Yep.